طيب السلام عليكم. My presentation is going to be a combination of English and Arabic. And today I'm going to be asked to speak about clinical audit. First, I have to say that I'm no expert in clinical audits. So what I'm going to be saying is just merely my experience from doing a couple of audits and for helping some of the colleagues looking and designing their audits and carrying them out. I'm very open if there's anything missing from the floor to add to state it out. So today, the main points I'm going to discuss with you will be what is an audit and why should anyone do an audit? What's the difference really between an audit and research? Because this is kind of a blurred picture in some people's minds. We're going to go through the audit cycle and what do we exactly mean by that and what the different stages in conducting an audit. And lastly, some tips which I think were useful to me anyway in carrying some of the audits. So a chronic audit, well, there's a couple of definitions. This one was by Working Party for Patients back in 1989 by the NHS, which say that it's a systemic critical analysis of the quality of the medical care, including the procedures, diagnosis, treatment, resources, and the resulting outcome and quality of life for the patient. Now, that's another definition in the next slide, sorry, please, which is by the NICE, which is the National for Clinical Excellence, National Institute for Clinical Excellence 2002. And it pretty much says the same. Well, it's a quality improvement process seeking to improve patient care and outcomes. They're talking about explicit criteria by which you measure these, and then they're talking about changes that have to be implemented and then re-audited to fulfill the cycle. Now, this guy in the bald head, that's me. I'm quite confused. So a simple one is a certain of care that you should achieve. How much do they meet or do not meet the standards is actually an audit. Okay, so what next? So there is a couple of reasons really why should we be doing an audit. One of them, it is very useful clinically and academically. Clinically, very obviously, because by measuring how much you are achieving a certain standard, and then you strive to try to achieve a better standard, and by thus you are improving the standard of care you're delivering to your patient. Academically, I find that that's an indirect usefulness of doing clinical audits, because once you do an audit, you should be mastering the area that you're looking to. Let's say you're auditing, for example, patients who are coming with an acute coronary syndrome in the A&E. How much of the set standards of investigations and treatment they should be getting? By doing that, you have to read into you have to master the management of acute coronary syndrome. You have to go through all the guidelines. You have to look into all of the evidence, and by this, your knowledge base will improve. So that's a major reason for doing an audit. Another reason is to encourage teamwork. Audit is never about a single person doing the thing by himself. It's always about building a team, looking into this. It makes it easier, and it encourages working with your mates and doing something useful for your patients collectively. And the third reason, of course, as we know, it improves patient care. Hopefully, if you come up with some strong recommendations which could be implemented, you can see immediately an impact on your patient care. Now, if you're not convinced by all of this, now you are obliged by the medical council to do an audit. We all know now that everyone in a one-year cycle of his medical registration has to do an audit, and it's become the request plus the CME points. So it's not up to you now. It's not optional anymore. One has to do an audit if he wants his registration within the medical council to improve. And I think one of the good things is also it makes your CV look good. I mean, if you work in a place and you've been there for a year or 6 months or 2 years, you haven't done any audit, it doesn't really reflect that you're keen on your work. But if you have carried a couple of audits, you can it reflects if you go for another job that you were helping in establishing a better working place. And that's very important. Can I drop this? I feel like a singer hanging this. Okay. An effective audit has a couple of elements, as you can see there. It's an educational activity. It promotes understanding resource-effective race standards, all of the things which you probably know by now. Let's go for the next. This slide is a bit busy, as you can see. It mainly outlines the differences between what we mean by research and what we mean by an audit. And in simple... sorry, can I? Sorry. As you can see there, in a clinical audit, you design and you conduct to produce information to deliver the best care. While in the research, you actually have a question you want to answer. So there is no set of standards that you want to achieve. Like, if you want to know if a drug X is better in managing hypertensive patient or not, okay? If you want to know how many of your patients coming with a certain specific criteria are getting this drug X, which is already agreed on a certain set of standard, this is an audit, okay? So it has to be very clear. There is a lot of mix-up between audit and research, and it's very important that you know how to differentiate between what's an audit and what's a research. So another point, for example, is that in a clinical audit, okay, you have the question is, does this service reach a predetermined standard? So you already have a standard. You're just evaluating if your service, this service could be a drug, could be an intervention, okay, could be an outcome. Could be an outcome. If you want to know, are 95% of patients with a history, let's say, I don't know this time, but let's say that 95% of patients who have a history of colonic cancer should be scoped every 2 years. I don't know if that is, sorry, going into your area, but let's say there is a standard like that. Okay, so if you're measuring, are your patients, 95% of them having a scope every 2 years, that's an audit. If you want to know, are these scopes any useful in detecting that you have a recurrence of your cancer, that's a research. Okay, so you have to have a predetermined standard to measure against. Okay, while in research you just have a question that you want to attain. In audits, unlike research, for example, the question of randomization is not that essential. In a research, any research have one of the major criteria is how did you randomize your sample. Okay, now we do use randomization in an audit if your sample size is, if your target population, is huge, and you want to, you can't include everyone, but it is of less significance in an audit as compared to a research. It can, for a research, if you don't do proper randomization, it just becomes void-like. So, next slide, please. So what clinical audit is not? It is not research. So it is about determining the best practice, but it doesn't answer a question. It is not about collecting data and analyzing it. You have to have set standards. It's not about just going there, collecting as much data as you can, and trying to make sense out of it. No, it's about, and it is not about finding a fault. And that's one of the main things now, because many people now, although understandably think that, okay, we are not doing our best here, let's do an audit and see, are we meeting, well, most probably not meeting the standard. But it's also an audit is a chance to show that you are meeting the standard. You can actually sell yourself well with an audit. Listen, our target was to see all the patients which were referred to us in a week, and actually, guess what? We saw them in 5 days. That means your department is doing really well. So it's a good chance to sell yourself and your department effort and celebrate whatever you're doing. So that makes me go to the next slide, which is all people talking about the audit cycle. And in the audit cycle, your starting point is what's the problem? Okay, and you have to say is that I get too many pleas from the nurses. Okay, that's my problem now. The nurses are bugging me, they're pleading me 10 times in 1 hour, and you want to audit that. So you have to go and find a standard. We'll get to that in a moment. So, and I always find from my colleagues and from junior colleagues especially that say, oh, I'd love to do an audit, I do want to do an audit. I just don't know what topic. I don't know what to do. So how can you go around and shop around for topics? Well, one of the ways is that is your personal observation. Can I have the next enter, please? Thanks for. Okay, so one of the things is the personal observation. As I said, you're working in a hospital. You see that that you're not meeting your expectation. Like you are expecting that. Well, I'm seeing these patients regularly. Okay, in the clinic, I'm expecting that they will do well. They're not. Okay, and you want to audit why. All right? So you have to go and see your standards. So one of them is your personal observation. The example I said about the nurses is also a valid one. Another way of picking your audit is to go through the guidelines. There's a lot of guidelines out there from different societies, from different Royal Colleges, from the NICE guidelines. And in this era, like where Google is at our tips, if you write anything and you Google it, I guarantee you like 1,000 websites will show up, on this topic. It's unlikely that you're going to audit something which nobody audited before. This is quite unlikely, okay, which is good in a sense. You can also, your audit could be a re-audit. So let's say you came to our department, somebody last year did a certain audit, came up with certain figures, okay, and it is presumed in the department that, well, we have addressed this problem. You can simply repeat the audit, and that's an audit. Okay, and actually you're closing the loop of the audit, and you can easily reflect that we had this situation, we had this intervention, this is the second audit, we did well, it didn't improve at all, things went worse, whatever, So that's another way of getting a topic. And the beauty about audit, it can be simply a copycat. You can go to a meeting, you read a poster. Somebody did an audit in St. James's about, the patient satisfaction in the oncology department, for example. You can take this exact audit and repeat it in the matter. There is no limitation. It's very difficult to do that if you're doing a research. If somebody published a research about a certain intervention or drug or whatever, okay, and came up with something, it will be quite silly, to put it in a mild way, to just repeat the research, unless you do something different. That could be that your sample size was greater. That somebody did a research on a drug, and his sample size just completed 100. Then, well, if you want to do the same research, you have to go for a bigger sample size, okay? You have to do something else. You have to change the dose. It's not a simple copycat. But for audits, it's a simple copy and paste. You can see whoever did an audit, you take it and you repeat it. And you can come up with something completely different. A problem in St. James's could be completely different from Kilkenny. Completely different, and that's why your audit will show a complete different results. Okay, so auditing in most audit papers that I went through, they will divide that what you can audit is either a structure you want to audit, such as your resources. So you want to audit the knowledge, you want to audit skills, you want to audit attitude of people, or you're either auditing a process. Okay, so, and this is usually falls in the criteria of the protocol. So if you want to audit patients who have been screened, you have to audit patients who are getting certain set of interventions done to them. That's your auditing a set protocol. Or you can audit the outcome. Okay, and the outcome usually most commonly audited is like patient satisfaction and the cost effectiveness of what you're doing. So these are the three groups really which audit falls into. Now, after you have identified your problem, okay, so yes, I'm going to audit this X, Y, I'm going to audit in the topic you have chosen. Okay, so before that, what is a criteria? Sorry, no, next slide. What is a criteria? So the criteria is defined as the aspects of care you wish to examine, while the standard are the pre-stated or implicit levels of success you wish to achieve. What does that mean in simple English? Okay, if you say, let's take this audit, 95% of patients referred to the department will be seen by a team member within 24 hours. Okay, that's the standard. That's the standard you want to achieve. Okay, I want 100% of patients who underwent laparoscopic surgery to be pain-free in the first 2 hours. That's the standard. Okay, and you can see a standard is made up of a criteria. So this in red, the patients referred to your department, that's your target group, and your targets. So when you put them together, you get your standard. Okay, and that has to be very, very clear when you're setting your audit. Otherwise, you just get lost in the middle. Next. Okay. Then you have to address what are your aims and objectives. And the aim is the general intent. An aim is a very generalized statement. Okay, so you want to ensure the compliance with certain guidelines. You want to ensure the compliance with the British Thoracic Society, for example, guidelines in managing asthma. Okay, you want to see, are you compliant with these guidelines or not? Okay, while the objectives, if you go to the second, the objective, it has to be very specific. it has to be something which is quite specific, to the point, and measurable. So you want to quantify the appropriate use of chest X-rays. Of course, this is an incomplete statement, okay? So you have to quantify the appropriate use of chest X-rays in patients, for example, preoperatively, okay? You want to see who should have got it and who didn't and why, all right? And there's also this statement about that any good standard has to be smart, specific. They're very clear and understandable. Anyone who reads them understands what you're talking about. They have to be measurable. They have to be achievable. You don't set standards which are not achievable. You say like, my standard is 100% of patients attending the diabetes clinic should be should be cured within a year or something, I mean, you have to set something which is logical, like, or 100% of chronic pain patients, or patients with lower back pain will be discharged from the pain clinic within 6 months, for example. You don't put things which are completely absurd. You have to be relevant, of course, to the realms of the audit. You don't audit things which have no sense, like, and have to be theoretically sound as well. So next, once you have agreed to the criteria and the standards you want to measure, phase. Okay, the data collection phase. Next, please. So the data collection phase, what I want to say is that there is no right way of doing things. Different people will tell you different ways of collecting the data. And it actually depends on the type of the audit you're doing. It depends on the personnel you're doing. It depends on the audit, where you're getting your audit information from. Okay, so a psychiatric audit could be completely different from a surgical audit in terms of their design. They could be similar as well. But there's some questions you have to think about when you're dressing the audit, when you're designing your audit. One of them would be who will be involved, who's your team. And try as much as you can to get as much people as possible in your team for different reasons. First, you want them involved if you want a change to happen. If you're auditing, if you think that chest X-rays are requested more than needed, like the request for chest X-ray, there's no real need for all this. You have to get the radiology department in, because otherwise, when you come up with a recommendation, okay, they won't fulfill it. They haven't been part of it. Okay, I recently did an audit about proximal fractures, proximal femur fractures. Okay, and we didn't have the orthopedic team involved with us. We were looking, we're following the guidelines. We want to see how many of the percent of the patients who presented with proximal femur fractures, actually they had their femurs or the neck of femurs fixed within a certain limit of time. The orthopedic team wasn't involved. So whatever we came up with, they said, oh, listen, we were not involved here. We don't take this on board with us. So you have automatically excluded them. So if you want to implement a change so you can re-audit and see that there is a change of practice, well, excluding important people like the radiologists or the surgeons, you won't have this change effective. Okay, your data collection. So you want to collect the relevant information, not every information. Only the information which is relevant to the audit. Okay, people habitually, for example, collect demographics. Okay, when you start audit, first you say, okay, name, gender, age, whatever. If these information, okay, or something, if this information, if the age, for example, isn't relevant to the topic that you're auditing, there's no need to take it. You're just adding effort, You have to think about each question and each statement. And I'll tell you, it's easier when you have a long form. You give it to your colleagues, oh, would you mind filling this form for me, when you see this patient such as because I want to include him in my audit. When somebody gives me a form which is half a page, I'll fill it very quickly, tick, tick, circle, circle, that's it. If you give me a 4 pages form, I'll tell you now, I'll fill 1 or 2, and then, I'll try to, whenever I meet you in the corridor, try to sneak through the other door, So try to keep it as simple. And one of the ways of putting it simple is that you really collect the information you need. Okay? You have to think about what type of data. Is it quantitative? Is it qualitative? How are you going to analyze it at the end? Okay? You have to think about how is the data going to be collected. Are you going to get it from the charts? Are you going to get it from when you catch the clinics in the outpatient? Or are you going to do it retrospective? Are you going to look, get the charts and do it? Are you going to do it perspective? Okay? Or is it? Sorry. Okay. You have to think about the sample size, the selection, the data feed. Important point is about the validity and the reliability, okay? So if you're measuring something, if you're auditing something, how valid is the tool? Let's say you want to audit the patient satisfaction with the service that you're giving them, okay? How are you going to? Is a question of, were you satisfied with the service that you got? Is that enough? Is this a valid measurement for the thing you're measuring, for the thing you're auditing? And how reliable? And reliability is always about, you have simple ways you think about it. If two people are doing the audit, are they going to come up with the same result? If not, if there is interpersonal bias, then that is not reliable. And of course, you have to feel about when you're going to start, when you're going to finish. Next, you have to fly through the next. Okay, so this is repeating the same thing. An important point here, of course, is to stress the confidentiality. Okay. So your audit does not reveal, if somebody cannot trace back, it's only you and those involved in the audit who can trace information to the patient. This is a big thing here in Ireland, especially to those who are newcomers. Confidentiality is a big problem, is a huge issue. Now, a quick thing, one of our colleagues, some of you might have heard this incident, was doing an audit. He took the charts, he put them in his car. His car was stolen. Whoever stole his car wasn't interested in the patient's chart. So he took the charts out of the car, left them in a park. Okay? Next thing in the news, patient charts left in XX park, you know, a whole hoo-ha about that. Okay? And the whole thing was about the patient confidentiality was exposed to the public, like, you know. This is a big thing. Next one. All right. This is, piloting. This is very important, actually. Try to run 5 or 10 samples very quickly, because you will always pick up something that you have missed, okay? Or the question which is inappropriate, or a question maybe everybody's answering yes, yes, yes. Maybe you should look, was that question needed, you know? So pilot your audit, 5, 6, you know, a very small number, and check it again. All right, next please, Matt. After you have done your data collection, you did your analysis, you will identify the areas of improvement. Okay, well, I was auditing that 80% should be nausea-free in the post-operative period. Well, what 60% were only nausea-free. We fell before the standards. Why is that? So we have to look into the practice. If you're an anesthetist, did they get the antiemetics? Did they avoid certain drugs? Blah, blah, blah. You know, I could set a lot of examples, but they're going to, just for the sake of time, I'm going to move on to the next. After you identify your areas, you make the necessary changes. All right? After you make this, which hopefully you have the team involved in the initial phase so they can all implement the necessary changes. And after that, you hopefully re-audit your practice after you made the changes. There's no point, of course, re-auditing if there's nothing happened here. There's no point. Okay, you re-audit the practice, and hopefully you have resolved the problem or identified another area. Some people don't like to call it the audit circuit, the audit cycle, because cycle means you're just doing the same thing. Okay, it's more of an audit spiral. So once you have re-audited, you have solved the problem, but maybe some other problem showed up. You have to audit that, and you're moving in a spiral like. Okay, so next please. That's another way of saying the audit cycle. You can just slide contents of your review. What were your results? Recommendations for further auditing to close the loop. Okay. Now, quick tips. Always start small. If you're doing an audit for your first time, don't pick something big. Start something very, very small. Okay? And don't make it complicated. Minimize your sample. You only collect the data. Start really, really small. That's very important for the juniors now. And number 2 is to get everyone involved. Okay? There's no harm in getting everyone, your teammates, other departments, everyone. Listen, I'm doing an audit about this, blah, blah, blah. What do you think? And you will be amazed by how good ideas you will be, fired with. Okay? Make sure your audit is not a research. This is very important, because a simple thing, audit doesn't need an ethical committee review. They don't. Okay? Because they're just auditing a practice which has been going there. A research does. So even if you try to say that, okay, I'm going to crack on, I think it's an audit, and it turns out to be a research, and you didn't get an ethical committee review, you're going nowhere with the research. That's a corner element. You have to be realistic. You have to be realistic. Audit does take time. You cannot just do it by the by. You have to have an hour or half an hour or whatever your time allows to do the audit. Okay. Also pick something you think a change could be. I'm out of time, am I? Sorry. Pick something you can think you can, with minor adjustment, make a big change. Don't audit something, okay? Don't audit something where you think inflicting a change could be a problem, okay? Because people don't want that just, okay, there's a problem here, pointing out at the problem, but doing nothing about it. That's not very useful.
HSE budgeting, for example.
For example, HSE. Yeah. Clinical audit also help you, okay? So it shows you your own practice. Am I doing this appropriate? How could I improve, and it's also, as I said, time to celebrate if you're doing really well. All right, next, I think I almost came. I don't know how people heard about this term. It's coming more and more popular now, clinical governance. Wherever you go to an interview, they might ask you about clinical governance. It has been there in the UK for a while now. It's coming in, it is also in Ireland, but there's not much stress on it. But audit plays a central part. There's a lot of other things which do play a central part as well. But evidence-based medicine, all of these things are all interactive and make what this form as a clinical governance. I think that's it. Okay, so next slide. Has any questions?